Hey everyone! Welcome back to my channel, and if you're new here, I am Mariana and I interview the brightest minds of physical therapy. So if you want to increase your knowledge, start right now by subscribing to this channel, clicking on the bell so you don't miss anything, give us a thumbs up and share with your friends. Today, our guest is Santiago Argüello, and he is going to talk about the use of the McKenzie method to assess and treat musculoskeletal disorders in the neuro population. Santiago has a neuro background with over 20 years of experience, as well as Mulligan and McKenzie certifications. I hope you enjoy the show. Hi, Santiago. Welcome to PT Pro Talk. How are you today?
Fine, Mariana. Nice to meet you. Thank you for inviting me to your podcast channel. It's a pleasure for me that we can talk a few things today. I think this space is important as a break time to discuss major ideas, even in the pandemic time. Congratulations.
Yeah, absolutely. I really appreciate you taking the time today. So let's jump right in. So could you tell us a little bit about yourself, your career, and how did you get to where you are right now?
Okay, what about for me? I was born in Argentina and raised in Buenos Aires. Later on, I joined at National University of Buenos Aires to start a bachelor in physical therapy. Until the present day, I have been training and delivering classes in two universities, a state one, La Matanza University, and a private one, Maimonides University. And in other hand, I am actively involved with the Argentinian Physical Therapy Association as a member of the board, But as I look back on the past, 20 years ago, I started my professional practice in neurological disorders in BPhty. BPhty is one of the most important neuro-rehab centers in Latin America. There I developed the upper limb rehab area, and then I started to work early with the Dr. Friedman research group, a wonderful multidisciplinary group, neurologists, PTs, autists, bioengineers. There I took my first steps as a fellow of NIH grant. A fellow there. I remember that it was a very complex protocol about neuroplasticity and learning with TMS, transcranial magnetic stimulation, which is different and necessary conversation for another time. But the key research topics were neuroplasticity, learning, and spasticity. I was a very young PT, and I took a few courses in PNF, Bovat approach, neuromobilizations, among others. But I remember a special day, a very, very, very special day, when a PNF instructor told me, if you want to be a good neuro PT, you must be a good musculoskeletal PT, because the neurological patients are riddled with musculoskeletal disorders. I asked her, what was the best approach to treat these patients? And she told me, Santiago, I like celiacs, but I think McKenzie is the future. Okay. And I embraced these words strongly. And that time, 𝗂𝘁𝘁𝘁𝘁 was bringing MDT courses to Argentina. Therefore, I started my MDT training in 2003, and my brain definitely changed forever, because I never back assess my patients in the same way, both orthopedics and neuro patients. Since that day, I've been working in the link search between neuro and musculoskeletal disorders, maybe more focused in stroke and Parkinson patients, but in multiple sclerosis or spinal cord injury too. I discussed it and debated at great length with my NeuroPT group about this, because we were astonished with the patient's changes. I remember me saying, it's a pretty crazy. Holy Mackenzie, you know. but I didn't discuss it. But I didn't discuss this with the MDT community at that time. I thought, unless one knew exactly what was happening with those patients, I shouldn't talk about this with the Mackenzie group. Today, I think it was a big error for several years, you know?
Yeah, you are experiencing Mackenzie for almost 20 years now. So I'm curious to learn more. So how did you combine? Because that's not something that we talked a lot about. Like, we don't talk about like Mackenzie courses in general. So I'm just curious. So you consider your area of expertise neuro and musculoskeletal? So that's my next question. And why do you think it's relevant to assess musculoskeletal disorders in the neurological population?
Yes, I think I'm right in the middle. You know, my expertise is the clinical assessment. I remember another special day in my life. I was helping with the MDT courses organization in Argentina. Colin Davis stopped the course and said, okay, please listen carefully to Santiago and what he has to say to you about the MDT and neurological patients.
Oh, wow.
And I said,
what a responsibility.
whoa. Yeah, I took a big breath and I started to speak. Okay, and Colin ended his speech with a phrase, we want more PTs, Santiago, all of you should try to explore MDT approach in different clinical conditions, follow the system, trust in this approach, you know? And I said, wow.
That's pretty cool.
Okay. Yeah, it was inspiring for all PTs in that course, because, you know, today in Argentina, we have about 18 certified MDT practitioners, and about half of these are neuro PTs.
Oh, wow. So this is
not common.
Yeah, it's not a lot of PTs, and half of them are in neuro. That's not normal. I'm sure you were the model for them.
Yeah, you know, when I say right in the middle, for example, I was summoned for Argentine University Sports Federation, and I have involved in 2 university games in Taipei and Naples in 2019 to work as a PT with football and basketball teams. But at the same time, I had delivered lectures and courses about Parkinson, stroke, and motor control too. Your second question, why it's relevant? If you pay attention to the last 15 years, the physical therapy evidence grew a lot. Many PTs in musculoskeletal area, they have been talking about the significant motor control in the patient with neck pain, back pain, shoulder pain. However, the majority of these researches don't show you how to rule it out a specific source of pain, or how to subclassify patients in a reliable way, you know?
Yeah.
Let me give you an example. All the PTs know that spasticity is an upper motor neuron syndrome, velocity dependent. But this picture only fits perfectly in the spinal cord injured patients. But in stroke patients, spasticity is an upper motor neuron syndrome too, but not necessarily velocity dependent. It can be triggered for different causes and different situations. For example, a stroke patient with a score 2 in Ashworth scale for elbow flexors, spasticity could increase due to a poor sensory integration or an insufficient strength in trunk muscles or skin injuries, or due to a musculoskeletal disorder. This can be one or all together. You know, a neuro-PT have tools to assess and classify sensory integration issues or vestibular causes or monitor trunk strength in stroke patients. The majority of them are keen in detecting skin lesions too. Why does this happen? Why? Because evidence gives us clear directives on how to do it. However, when you analyze the research and clinical guidelines, they don't give us straightforward directions on how to detect or rule out the influence of musculoskeletal disorders in, for example, spasticity, you know? And this is what I saw, this lack of gold standard to assess the influence of musculoskeletal disorders in, for example, stroke patients. And this happened with the majority of the patients with neurological disorders. Maybe have been involved in these two areas, neuro and orthopedics, gave me the opportunity to spot this, you know.
So you saw there was something lacking, and because you had the knowledge in two different areas, and then you saw that something was missing in the neuro that you had on the musculoskeletal area. So how do you fill that void? So how do you use your musculoskeletal abilities in the neuro, and how does it work?
The clinical classification system used in MDT maybe utilizes on neurological patients who experience pain or present other symptoms triggered by these mechanical problems. Let's describe a picture of neurological patient, for example, a stroke patient, okay? When we analyze stroke patients, generally, they present great functional disabilities. They have gait problems, upper limb impairment, sensory impairment. So the majority of the activities of their daily living suffer great impact. When I present to you this picture of the neurological patient, pain seems to be left in the background. But why? Well, because the therapies are focused on improving this condition that are devastating for the patient, not being able to walk, not being independent to move the arm. Now, pain can be a problem affecting this situation, but there are other symptoms not necessarily present as pain, but they are set off by a musculoskeletal problem. For example, spasticity, as we are talking before. So expect when we're talking about hemiplegic shoulder pain, where pain is at the center of this scene, when a neuro patient presents low back pain, neck, knee, or ankle pain, these problems seem to be self-reported in the research literature. Let's move the neurological condition of the patient from this scenario we are describing. For many, many years, a great number of musculoskeletal conditions which generate pain have been treated without a suitable classification. This shows us the first problem. Now, what's the second problem that the musculoskeletal area faces nowadays? That there are still a lot of investigations being produced that don't take into account the problem I just described to you. So we have two big problems. Stick with the neurological condition out of this scenario. Just presenting one condition, the musculoskeletal condition. We see how there is in a major problem for musculoskeletal population. For example, first, increased use of medication. patients seeking and adopting alternative therapies which are not evidence-based, increased negative beliefs, and more individuals presenting chronic pain. Now, let's bring to this problematic scenario all the conditions we mentioned on the neuro patients, when the pain is self-reported or specific neurological symptoms are being misinterpreted. I know this doesn't sound very encouraging, right?
I mean, it sounds like we are trying to separate conditions and classifications, so it's hard to combine them. I think we are trained very specifically to neurologic, that musculoskeletal is something completely different. So I think our minds are trained just in one thing and we cannot see the whole picture. So
yeah, for this reason, we need to use a system that has an order, okay, that allow us to line up the pieces in the chessboard, you know, where the clinical presentation of the patient is the place. So we need to know which pieces to move to get the place we want. This is why MDT, I think, fits perfectly as a diagnostic system. MDT fits perfectly as a sanitary technology because it follows a procedure, it's a standardized, it's evidence-based, it's low cost because you only need an MDT-trained professional. And it's a tool that can be applied to different populations. Other sanitary technologies are very expensive and seem to be innovative as they have lights and make sounds or generate reports in real time, you know?
Technology.
Well, yeah. Well, the fact is that these technologies do not necessarily have the support of the scientific evidence to be used. These technologies don't educate our patients. Can you see where I'm going?
Yes, I can. I'm liking, keep going.
Yeah. Other fields in physical therapy have very good classification systems. We can see this in the respiratory physical therapy or vestibular rehabilitation, in which peripheral and central problems are well identified. These lead to the use of very precise treatment strategies adjustable to each patient. When we have this, patient prognosis become clear. You know, prognosis is getting better in the musculoskeletal field, but for neurological patients, that's very difficult. You know, okay, except in a spinal cord injury because the neuropathy have the H scale. In the another neurological conditions, it's very hard. My focus all this time has been to use Mackenzie method to get a better understanding and try to sub-classify the symptoms of the neurological patient. This, I believe, might help us have a better understanding of this amazing chess game, you know? It might seem simple to apply MDT in neurological patient. One may think it's only a matter of grabbing an assessment form and assessing a stroke patient to see if there is any mechanical problem. But however, from my point of view, it's not that simple. Because it's not matter to replacing words in a book, okay? When say spasticity, when say pain, put spasticity or sensory alterations, okay? Mackenzie brought a new way of clinical reasons. With the neurological patient, we must consider all the confusing variables that may have an impact on the outcome of my assessment. For example, a patient presenting spasticity in elbow flexors may have an elbow derangement, increasing this spasticity, or it can be because of a cervical derangement or the patient may present an ankle derangement. And when the individual stand up, they will flex or tone spike up, you know? But if we don't consider every aspect surrounding spasticity, the patient can get better the day of the treatment, but during the week, get worse nor better. So we need to take into account every component that has an impact on spasticity. Not necessarily we need to assess where the spasticity is shown, but we need to assess pain shown of that place, you know?
Make sure you're not missing anything, because it could be something more simple, like a derangement, because the population can still have all of these syndromes that we see in Mackenzie, I assume. So you just have to make sure you're not missing a derangement that could really improve the patient's condition, right? So like, do you have like a structure that you organize on your like assessment? Do you create like a step-by-step that you use using the MDT assessments? How do you go about that?
Yeah, the MDT form, it's a very good, maybe need a little change. Let me give you an example. For example, for a patient with Parkinson, who's experiencing cramps in the lower limbs, okay? We can ask, when do you have them? Morning, during the day, or at night? Okay, it's a very common question in the assessment form. When are they get worse? To make a slight but key difference, the correct follow-up questions will be, for example, if they get worse in the mornings, at what time do you have your medication? Because we need to know if those cramps are related with the medications beside the mechanical problem. Because they can have end-of-dose dystonia or peak dose dystonia and have cramps and also pain, you know? We cannot ignore this detail. As you can see, this is easy to spot during the story taking. Yeah? Yeah, a little change. I think that the McKinsey assessment form, it's wonderful, but I need a little change.
Is it like a little adaptations to the neuro population to identify these small questions that are relevant to that population? Because you have the knowledge on the neuro, so you know what kind of questions are important, and trying to kind of combine them on the assessment and then the reevaluation and all of that. I believe MDT should apply some change to the system for it to become more suitable for neuro patients, you know. But I think fits perfectly, you know. Do you think they're gonna develop any specific form for that at some point?
No, I changed. I used the regular form, but I changed the questions when I took the story taking, you know.
So you did it yourself, but it could be something official. They could be having PTs like you and others that use neuro, you know, and maybe adapt. That would help a lot of PTs, right?
Yeah, I think so. It's a good idea.
Yeah. So that's very interesting to apply these concepts to the neuro population. So let's transition to the final questions.
Okay.
What is your favorite resource of information? Do you have anything in particular that you like?
Okay. You know, I use PubMed. It's very common. But it's not enough to read a paper. We need to discuss the papers, you know? And this is not easy. We need a group, a PT group or physician, or a multiple disciplinary group, because it's not easy to read the evidence. You know, the evidence grew a lot every time, every day. And I think read and discuss are the key points with the results information. But I think the approach of Audrey Long, applied in-house investigation, is the approach we must follow for every population, you know. In the neuro world, I can mention two authors who are very good for me, at least. And they are Sean Krakauer. The another one is 𝗂𝗁𝘂𝘁. Yeah, both are going to open up a lot of mind, I think.
Good, that's important, especially in this universe, trying to combine things. You have to have an open mind, right?
Yeah.
And what would be the best advice you give to the clinicians that are starting their careers?
Every day at university, I say, do not focus on treating patients, focus on assess of the patients. This is a key point, but for other hand, I think keep doing things you like outside the world of physical therapy. You know, we cannot only study physical therapy to become good PTs. We need to have a global knowledge and a wide general culture, because in that way we can really have a biopsychosocial approach to understand and treat our patients. You know, I think this is important. Not just only read the papers. Okay.
Yeah. And I think it's becoming more of an issue that people are realizing and talking more every time, more and more about it, because you can have just your PT skills if you don't understand the biosocial and all of the other components. So I think that's very important too.
Yeah.
And what personal qualities or abilities that you think are important to become a successful PT?
I think communication. Being able to generate a back and forth communication with the patient is essential. Other one is being curious. You know, Cesar Milstein, Prize Nobel, talked a lot about this. He said the curiosity, like that innate curiosity we have when we are kids and explore the world and try to understand how it works and how things happen. That curiosity is what PT should keep in their inter-careers, you know? And for other hand, I think another good point, challenge the statements with a critical view on how to enhance that statement, not to overthrow that statement, because the statements are like steps to climb and keep going up, you know?
Yeah, awesome. So, Santiago, if people want to learn more about you or have more information about your work or exchange information, because that's a new kind of area that we see, like relating MDT and Neuro. So if they want to exchange information and ask questions or anything, do you have like a contact info that you could give us?
Yes, if you want, I'm gonna send you my formal emails, and please share.
Yeah, sure. Absolutely.
Yeah.
So thank you so much for taking the time to be here with me and share all this knowledge, because maybe we have some listeners that are curious about the topic and it's something that's not very common. So I really appreciate you come here and spread the word and help me to bring this information to other PTs. And I really appreciate it.
Okay, thank you, Mariana. Thank you. I hope to have contributed to take off another brick on the wall, you know?
Yeah, I'm sure you did.